Hello everyone, I am Dr. J. Priyanka, Assistant Professor, Department of Pharmacy Practice, School of Pharmaceutical Sciences, VISTAS. Today we are going to discuss one of the most important topics in pharmacology and pharmacy practice, adverse drug reaction, commonly known as ADR. Medicines are prescribed to treat diseases and improve the quality of life. However, sometimes medicine themselves can produce unwanted effects. These reactions may be mild, severe, or even life-threatening. Therefore, every healthcare professional must know how to identify, manage, and prevent ADR. In this session, we will learn the definition, classification, causes, prevention, and pharmacovigilance of ADR. And definition of ADR. First, let us understand what an ADR is. An ADR is defined as any harmful or unintended response to a medicine that occurs when it is administered at normal therapeutic doses. Notice that this definition specifically mentioned normal doses. This means the patient has taken the medicine correctly but still experiences an unwanted effect. An ADR may require medical treatment, reduction of drug dose, discontinuation of therapy, or extra caution if the same medicine is used again in the future. For example, a patient taking penicillin develops a skin rash despite receiving the correct dose. This is considered as adverse drug reaction. Now let us differentiate between ADR and ADE. An ADE refers to an unwanted medical event that occurs during drug treatment. However, the medicine may or may not be cause. For example, if a patient slips and falls while admitted to the hospital and receiving medication, it is an adverse event, but not necessarily caused by the medicine. On the other hand, if the patient develops severe bleeding after taking warfarin, the medicine is responsible. Therefore, it is an ADR. The simple way to remember this is every ADR is an ADE, but not every ADE is an ADR. This next slide explains the factors that increases the risk of developing ADRs. Certain patient groups are more vulnerable. These include elderly patients because their liver and kidney functions are reduced. Children are also at higher risk because their organs are still developing. Patients taking multiple medicine known as polypharmacy have a greater chance of drug interaction. Pregnant women require special attention because some medicines can affect the developing fetus. Patients with multiple diseases, malnutrition, immunosuppression, and drug abuse are also more susceptible. Remember that ADR can occur immediately after taking a medicine, after prolonged use, or even after the medicine has been stopped. ADR are classified based on their severity into 4 categories. The first is minor ADR. These reactions are mild and usually do not require treatment or hospitalization. Next is moderate ADR. These reactions require a change in therapy, additional treatment, or may prolong the hospital stay. The third category is severe ADR. These reactions are life-threatening, may cause permanent disability or even intensive care. Finally, lethal ADR are those that contribute directly or indirectly to the death of patient. Recognizing the severity helps clinician decide the appropriate management. There are several ways to classify ADR. The most commonly used classification is ABCDEF Classification. Type A stands for augmented, Type B stands for bizarre, Type C means continuous, Type D means delayed, Type E refers to end of use, Type F means failure of therapy. Broadly, ADR are grouped into 2 major categories. Type A reactions are predictable and related to the pharmacological action of the medicine. Type B reactions are unpredictable and usually result from allergy or genetic factor. We will now discuss each type in detail. Type A reactions are also called as augmented reactions. These reactions are predictable because they are based on the known pharmacological action of the medicine. They account for nearly 75% of all ADRs. They are dose related and are usually preventable. Examples: warfarin causing bleeding, antihypertensive drug causing hypotension, insulin causing hypoglycemia. Since these reactions are predictable, Proper dose adjustment and patient monitoring can prevent most of them. Type B reaction are also known as bizarre reaction. Unlike type A, these reactions are unpredictable. They are not related to the dose or the normal pharmacological action of the medicine. Most occur because of drug allergy or genetic predisposition. These reactions are often serious and require immediate discontinuation of offending medicine. For example, a patient developing anaphylaxis after receiving penicillin is experiencing a type B ADR. Type C refers to continuous or chronic reaction. These occur after long-term exposure to a medicine. They are usually associated with cumulative drug effect. For example, prolonged use of NSAID can lead to interstitial nephritis or papillary necrosis. These reactions highlight the importance of regular follow-up and monitoring in patients receiving long-term therapy. Type D reactions are called as delayed reactions. These reactions appear months and even years after exposure to the medicine. One of the classic examples is thalidomide, which caused severe congenital limb deformities known as phocomelia when used during pregnancy. Other delayed effects include carcinogenicity, mutagenicity, and dyskinesia after long-term drug therapy. Now let's discuss type E adverse drug reactions, where E stands for end of use. These reactions occur after a medicine is suddenly stopped rather than while taking it. Many medicines cause the body to adapt to their presence. If these medicines are discontinued abruptly, the body reacts by producing withdrawal symptoms or rebound effect. For example, if a patient suddenly stops taking beta blockers after long-term therapy, they may develop rebound tachycardia and hypertension. Similarly, abruptly stopping corticosteroids may result in adrenal insufficiency. Therefore, medicines such as beta blockers, corticosteroids, and benzodiazepine should always be withdrawn gradually under medical supervision. Never advise patients to stop long-term medication abruptly unless instructed by their physician. After understanding ADRs, the next important concept is pharmacovigilance. Pharmacovigilance is the science and activities related to the detection, assessment, understanding, and prevention of ADR and other drug-related problems. Its primary objective is to ensure that medicines remain safe throughout their use. The information collected through pharmacovigilance helps the regulatory authorities issue safety warning, update prescribing information, restrict the use of certain medicines, or even withdrawal unsafe medicine from the market. As future pharmacists, reporting suspected ADR is one of your professional responsibilities. Now, let us see the important activities involved in pharmacovigilance. The first activity is post-marketing surveillance, where medicines are continuously monitored after they are introduced into the market. Healthcare professionals voluntarily report suspected ADRs. Other methods include prescription event monitoring and hospital-based ADR monitoring programs. The collected information is analyzed and shared through drug alerts, medical letters, safety advisory, and regulatory notification. Based on these reports, authorities may update drug label, introduce new warnings, restrict drug use, or even withdraw medicine from the market if they are found to be unsafe. This continuous monitoring protects millions of patients worldwide. Next slide explains how ADR reporting works internationally and in India. The Uppsala Monitoring Center in Sweden serves as the International Coordinating Center for Pharmacovigilance. In India, ADR reports are collected through national and peripheral monitoring centers located in medical colleges and tertiary care hospitals. Doctors, pharmacists, nurses, and other healthcare professionals report suspected ADRs to these centers. The reports are analyzed, and if a consistent safety signal is identified, appropriate guidelines are issued regarding the safe use of the medicine. This reporting system plays a vital role in improving patient safety. One of the most important responsibilities of healthcare professional is preventing adverse drug reaction. The first principle is rational prescribing. Always prescribe the correct correct medicine at the appropriate dose using the correct dosage form, route, frequency and duration. Before prescribing any medicine, ask the patient about previous allergies or adverse drug reaction. Review laboratory investigation, especially liver and kidney function tests, because impaired organ function can increase the risk of ADR. Most importantly, whenever a patient develops a new symptoms after starting a medicine, always consider the possibility of an ADR before prescribing another medicine. This simple approach helps reduce unnecessary medication and improve patient safety. Next slide summarizes the different types of adverse effects produced by medicine. These include side effects, secondary effects, toxic effects, intolerance, idiosyncrasy, drug allergy, photosensitivity, drug dependence, withdrawal reaction, teratogenicity, mutagenicity, carcinogenicity, and drug-induced diseases. Each of these reactions has a different mechanism and clinical presentation. In the next few slides, we will discuss each one separately. First, side effects. Side effects are the most commonly encountered adverse effects. They are predictable, unwanted pharmacological effects that occurs at therapeutic doses. For example, antihistamines commonly cause drowsiness. Benzodiazepine produce sedation and impaired coordination. Interestingly, a side effect may sometimes become a therapeutic effect. For example, codeine normally causes constipation, which is an unwanted effect in most patients. However, the same effect becomes beneficial when treating patients with diarrhea. Therefore, side effects are not always harmful. Sometimes they may be used therapeutically. Next, secondary effects. They are indirect consequence of the primary action of a medicine. Unlike side effects, they occur because the drug alters normal body function. For example, corticosteroids suppress the immune system. As a result, patients become more susceptible to infection and dormant tubi may become active. Therefore, while prescribing corticosteroid, physicians carefully monitor patient of sign of infection. Next, toxic effects. It occurs when a medicine is taken in excessive dose or used for prolonged period. These reactions are predictable and dose dependent. Organs commonly affected includes brain, heart, kidney, liver, lungs, skin and bone marrow. A famous statement by the physician says, "It is the dose that makes the poison." This reminds us that almost every medicine can become toxic if the dose is too high. Next slide. Toxicity may simply represent an exaggerated pharmacological effect. For example, excessive anticoagulation with heparin results in severe bleeding. Excessive action of digoxin may produce complete heart block. Poisoning occurs when exposure to a substance severely affects one or more vital organs and threatens life. Early recognition of toxic effect is essential. Now, let's discuss intolerance. Drug intolerance is the occurrence of toxic effects at normal therapeutic doses because a particular individual has an unusually low tolerance to the drug. In other words, even though the patient receives the correct dose, they develop exaggerated adverse effects. For example, carbamazepine may cause ataxia or loss of coordination only after a few doses in certain individuals. Remember this point, intolerance is dose related, but the patient's sensitivity is unusually high. Next is idiosyncrasy, one of the most commonly confused topic in pharmacology. Idiosyncrasy is a genetically determined abnormal reaction to a drug. It is an unusual response seen only in certain individuals because of their genetic makeup. Unlike intolerance, idiosyncratic reactions are not dose dependent and cannot be predicted from the normal pharmacological action of the medicine. For example, chloramphenicol may cause aplastic anemia in rare individuals. Barbiturates may produce excitement instead of sedation. So remember, intolerance is increased sensitivity, idiosyncrasy is genetically abnormal reactions. Now let us discuss about drug allergy. It is also known as drug hypersensitivity, Drug allergy is an immunologically mediated reaction that is unrelated to normal pharmacological action of the medicine. Interestingly, allergic reactions can occur even with very small doses because the body's immune system reacts to the drug. Common symptoms like skin rashes, itching, angioedema, anaphylaxis. Examples include allergies caused by penicillin, sulfonamides, and certain vaccines. The first step in management is to stop the offending drug immediately and provide appropriate treatment. Mechanism of drug allergy. How does a drug allergy develop? When a drug enters the body, it may behave as an antigen or more commonly as a hapten. The immune system recognizes it as a foreign substance and produces antibodies or sensitized lymphocytes. On subsequent exposure, these immune cells react rapidly, producing allergic symptoms. An important point to remember is that prior exposure may or may not be evidence, making allergic reaction difficult to predict. Types of allergic reactions. Drug allergies are classified into 4 major types. Type 1 is immediate or anaphylactic reaction. Example, penicillin-induced anaphylaxis. Type 2 is cytotoxic reaction. Example, drug-induced hemolytic anemia. Type 3 is immune complex reaction. Example, serum sickness. Type 4 is delayed or cell-mediated hypersensitivity. Example, contact dermatitis. These classifications are based on immunological mechanism responsible for the reaction. The next topic is photosensitivity. Some medicine increase the skin sensitivity to sunlight. This condition is known as photosensitivity. There are 2 types. The first is phototoxicity. Here, the drug absorbs UV light and directly damages skin cell, producing redness, blistering, and sunburn-like reaction. Examples include tetracyclines and fluoroquinolones. Patient taking these medicines should avoid excessive sunlight and use sunscreen. Next is photoallergy. The second type is photoallergy. Unlike phototoxicity, photoallergy is an immune-mediated reaction. After exposure to sunlight, the drug triggers an allergic response, resulting in itchy, eczema-like skin lesions. Drugs commonly associated with photoallergies include sulfonamide, sulfonylurea, griseofluvin, chloroquine, and chlorpromazine. The best prevention is limiting sun exposure while taking these medicines. Now let's discuss drug dependence. Drug dependence is the condition in which a person continues using a medicine because the body has adapted to its presence. There are 2 important types: physical dependence and psychological dependence. Physical dependence, where stopping the drug causes withdrawal symptom. Psychological dependence, where the patient feels an emotional need to continue taking the drug. Examples: opioid, barbiturate, benzodiazepines, and alcohol. Next, drug abuse means using a medicine without medical supervision or in a manner different from approved medical practice. Drug addiction is more serious. It is characterized by compulsive drug-seeking behavior, where obtaining and using the drug become more important than normal daily activity. Drug abuse can eventually progress to addiction if not recognized and treated early. Next is drug habituation. It is also called as psychological dependence. In habituation, there is only a mild desire to continue using the substance. So, stopping the substance causes only mild discomfort and does not produce severe withdrawal symptoms. Example: tea, coffee, tobacco, and social alcohol consumption. Remember, habituation is milder than addiction. Next is drug withdrawal reaction. Withdrawal reaction occurs when long-term therapy is stopped suddenly. The symptoms are often opposite to the effect of the medicine. For example, abrupt discontinuation of corticosteroid may cause acute adrenal insufficiency. To avoid withdrawal reaction, medicine should usually be tapered gradually instead of being stopped abruptly. Next is teratogenicity. Teratogenicity refers to the ability of certain medicine to produce congenital abnormality in the developing fetus when administered during pregnancy. The most critical period is organogenesis, between approximately 18 and 55 days of gestation, when the developing organs are highly susceptible. Examples: thalidomide, warfarin, ACE inhibitor, barbiturates. Therefore, prescribing medicines during pregnancy require careful risk-benefit assessment. Next, mutagenicity and carcinogenicity. Some medicine can damage DNA. If they cause genetic mutation, the effect is called mutagenicity. If they promote the development of cancer, the effect is called carcinogenicity. Examples include certain anti-cancer drugs, radioisotopes, estrogen, and tobacco-related chemicals. Although these reactions are uncommon, they are extremely important in long-term therapy. Next, drug-induced diseases. Some medicines can themselves produce diseases. These are called drug-induced disease, or examples: hepatitis causes by isoniazid and rifampicin. Peptic ulcer is caused by salicylates and corticosteroid. Retinal damage is caused by chloroquine. Thank you everyone for your attention. Let's quickly summarize today's session. We learned the definition of adverse drug reaction and how they differ from adverse drug events. We discussed ABCDEF Classification of ADR, Pharmacovigilance, prevention strategies, and various types of drug-related adverse effects, including intolerance, idiosyncrasy, allergy, photosensitivity, drug dependence, withdrawal reaction, teratogenicity, mutagenicity, and drug-induced diseases. As future pharmacists, your role extends beyond dispensing medicine. You are responsible for identifying, reporting, preventing, and educating patients about adverse drug reaction to ensure the safety and rational use of medicine. Thank you, and I wish you all the best in your studies. See you in my next lecture.